And what is the amount of the average WIC grant for participant?
Let's see. That is outlined in the estimate because it varies by participant category. Let's see if I can find that. It had been about $60 per participant. Now that we've broken it down by participant category, it's more expensive for infants because of the infant formula, and then it's less than $60 per all the other categories.
Yeah, and can the WIC grant be used for any purchase of fruits or vegetables,
Yes.
non-dairy?
Yes, absolutely. So the WIC program authorizes a variety of foods. In 2009, there was a major change nationally to the WIC program, and so we authorize fruits and vegetables, both fresh, frozen, and canned. And we are recently, last year, the USDA increased that dollar benefit for participants. We also authorize whole grains, so there's whole grain foods. We're looking at other options now. The federal regulations about whole grains changed last year, so we're looking at whole grains pasta. There's less juice on the program as of 2009 than in the past. Lower fat milk, so there's dairy, protein, infant formula, baby food, fresh fruits and vegetables, and also the WIC checks can be used at farmers market that are authorized for the WIC program as well, so not just in grocery stores.
Excellent. I think you're catching my drift about where I was headed with the incidences of child obesity and other issues around illness and nutrition. And certainly in my district, I represent 2 school districts where at least 50% of the kids are considered obese or have diabetes or some other form of illness. I wanted to be sure that our programs allow the participants to purchase fresh fruits and vegetables and non-sugary items and things that will be helpful to prevent these illnesses.
I just wanted to add, too, that it's not just about giving people the vouchers to go and buy healthy food, but it's also the the participant comes in for their session and they learn about nutrition and nutrition needs of children and educates them about this so that by the time that they graduate from the WIC program that they're able to do this on their own.
Fantastic. Let's go. Ms. Jones.
Did you say some of the farmers markets accept EBT? Or
WIC.
WIC?
Yes.
So when you switch to EBT, have you?
Yes.
My understanding is a lot of farmers markets are cash only. So how will that work?
What we do, so we'll prepare them for that, and they're also farmers markets that accept WIC checks also accept SNAP EBT already.
Oh, so they're already set up for that electronic. Okay.
Yeah, one of the changes that we made in our vendor authorization criteria was last year is that any store or farmers market that is authorized to accept WIC must also be authorized for SNAP. So all of our vendors are EBT ready, will be ready for us. So by the time we're there, it should go very smoothly.
I know that our farmers markets in Berkeley and Oakland accept credit cards, so when you visit the Bay Area next, Mr. Jones, you'll be my personal guest. Just bring your credit card. Member Grove.
Thank you. Okay, so I could be wrong, and if I am, please correct me, but I thought there was some type of restriction on sugary drinks and sodas and things like that you could not buy from WIC coupons. Isn't there some type of categorical healthy food requirement?
The WIC program does not authorize sugary drinks or
I didn't think so.
anything like that.
That was just a question that Mr. Thurman asked, and I thought it had already been corrected that they didn't offer that.
WIC does not authorize those foods.
Thank you.
Good clarification. I just wanted to make sure that there was the availability, the opportunity to offset any sugary benefit from greens and healthy things, fruit, natural fruits, natural sugars, and things of that nature. One last question about participation rates. Are there areas in the state that you have seen that are below? Yeah, I was excited to hear that we're above the national average, but are there areas in the state that need additional assistance in getting up to participation levels? And if so, what are they?
We have not finalized the report, so I don't have the list of where they are, but we are seeing that there are some, variances in the coverage rates across different counties and in different of the participation categories. So as soon as we have that finalized, we will be focusing in on those areas to provide them additional assistance, help understand what their barriers and challenges are, and focus our efforts to improve their participation rates.
We'll look forward to your report. Thank you. Thank you. Public comment.
California WIC Association, which is the member association for the 84 local WIC agencies in California. I just wanted to applaud the great work that the WIC program has been doing this last year. You heard these major undertakings, and the Grocer Initiative was leadership, national leadership is what came out of that. And as far as the end product and the complex project that they undertook for cost containment and integrity, and we're really proud of that. There's been great effort made to really look at participation and really serve the moms and babies and children and how to have really quality services. And of course, that's really important to the local agencies who are out there delivering the services and developing those relationships with the moms and babies. And the WIC EBT is going to really help us with that participation and the MIS system, and that's a huge undertaking also, especially since we have such a large state. And we just wanted to applaud all those huge undertakings all simultaneously and continuing to serve a lot of 1.4 million participants a month. So I just wanted to lend support for the WIC program there.
Thank you. We're going to move on to issue 4, the genetic disease screening program estimate. Thank you, panelists. Dr. Mitchell, you may stay. And we invite up Leslie Gaffney, Assistant Division Chief, Genetic Disease Screening Program, Center for Family, DPH, and John Bajikalupi and Jamie Metallica and Mr. Martin.
So I spoke a little bit earlier about how in the Center for Family Health we try to do this kind of wraparound approach to getting all children off to a healthy start. The genetic disease screening program screens both pregnant women for genetic and congenital disorders and as well as children. Newborns in California, almost all newborns are screened for a whole panel of genetic diseases. Leslie Gaffney is the Assistant Division Chief of Genetic Disease Screening, and so similarly I was going to have her walk through the estimate for you and answer any questions you have.
And so thank you to your staff for the really comprehensive overview. The Genetic Disease Screening Program provides services to both pregnant women and newborns. As Connie said, we screen just about every newborn in the state. This year, we are coming to you, the real take-home from this message is that we're asking for an increase of $2.5 million specifically for our newborn screening program. Of that, about a little bit over $500,000 to address caseload increases and slight increases in cost for services. And the rest, $1.975 million, is part of the BCP that we'll discuss. And the increase to start work on AB 1559. So AB 1559 would require us to screen for adrenoleukodystrophy, which is a peroxisomal disorder. Peroxisomal disorder. A disease that takes place in the peroxisome, which is inside your cell. In particular, adrenoleukodystrophy is an X-linked disorder, which means it affects boys almost exclusively. And this disorder is one that doesn't surface until boys are about 6 years old. It presents like attention deficit disorder, so a lot of boys are misdiagnosed to start with until they have a crisis, and then it leads to brain damage, blindness, and eventually death. However, if they're identified before symptoms take hold and are given a bone marrow transplant, it essentially ameliorates the disease. A mechanism...
Is that the only medical treatment is a bone marrow transplant?
Currently, yes.
Yes, okay, sorry.
Yes. So last year, AB 1559 passed and requires us to add screening for ALD, adrenoleukodystrophy, as soon as the disorder is added to the federal recommended uniform screening panel. The Federal Health and Human Services Agency and the American College of Medical Genetics has a committee called the Discretionary Advisory Committee on Heritable Disorders in Newborns and Children. And they look at different disorders to be added to the newborn screening panels across the country and make a recommendation for a minimum standard that states should adhere to. They have a rigorous process where they review diseases for medical and then public health appropriateness for screening. And once it's passed through both those processes, the larger committee makes a recommendation to the Secretary of Health and Human Services, and then she makes a recommendation or a denial to put the disorder on the list. So ALD has made it past the first step of the process, and it's been through the medical review. It is currently out to the Committee on Public Health Review. The Discretionary Advisory Committee meets 3 times a year. They just met in February. They will meet again in May and again in September. So we're watching ALD as it moves through the process. So we have a fairly good idea when it will at least be presented to the Secretary, and the scuttlebutt that we hear is that it will make it through the Public Health Committee and will be recommended by the full committee probably at the September meeting. And then it's up to the Secretary. She can review it and add it immediately. She can take years to add it. But we have a feeling that she's probably, once it's put forward to her, that it seems the type of disorder that would be added. The problem with AB 1559 is it requires us to start screening for the disorder as soon as it's on the list. So we don't have the luxury of waiting till it's added to the list by the Secretary and sitting back and then making changes to our program. We need to be ready to go. So the $1.975 million that we're asking for is for one position, which is an ongoing position, and that's $150,000 a year ongoing, and then a $1.825 million one time to make changes to our computer system and get ramped up and ready to go so that when it gets added, we're ready. There was a question about what we would do if we made these changes and ALD never got added to the list. If that were the case, then we would have to pay some more money, but we would be able to use the coding changes that are in the computer, and the bulk of that $1.8 million is for coding changes to our computer system. We would then utilize the changes that have been made and tweak them for the next disorder that comes down the road. And we know there will be something else we'll be adding to the newborn screening panel. We've gone since 1980 when we started with 3 disorders. We're at 80 now, and 80. So the nature of genetics is there's always something else. There are probably 10 to 20 disorders out there in the field now that have tests ready to go, and it's more about the efficacy of the treatment that's available. You don't want to diagnose a baby with something and not be able to treat the baby. So they're working on treatments as well at the same time. So we know there'll be something down the road.
I just wanted to add one thing, the peroxisome. It's a little organelle in the cell. It wasn't, people didn't even know it was there when I went to medical school many years ago, but it handles the metabolism within the cell, and so you can either not develop this little organ in each cell. It's in every cell in our body except for the red blood cells. So you can either not develop it correctly or it cannot process a certain enzyme correctly. So this particular disease is because of a deficiency in the metabolism of the peroxisome. So there's about 10 diseases that are called peroxisomal disorders because they all fall into that same category.
Thank you, Dr. Mitchell and Ms. Gaffney. Anything from Finance?
Sure. John Botchgalupi, Department of Finance. With regard to the staff recommendation, I'd just like to add that the administration is always open to discussing further the proposals before the subcommittee, just with respect to the comment and the recommendation about the timing of approval of adding ALD to the federal panel and the funding of the BCP. We're always open to discussing further proposals before this subcommittee with ledge staff to a successful resolution.
Thank you. Anything from the LAO's office?
Sean Martin with Legislative Analyst's Office. We support the staff recommendation. We think it makes sense to see how far along we are in the process in May before we make a final decision. And we also think that it makes sense to add the provisional language to assure that these funds will only be spent for the purpose that you're appropriating them for.
Thank you. Questions from the committee? Ms. Grove.
Thank you. Sorry. And this is just so I can better understand it. It's obviously, when you deal with children's lives, you want to make sure your kids are safe. The screening, it's my understanding that if you screen and spend the resources to screen all these kids, even if you save a certain percentage of them, the treatment for the state or the cost for treatment is much less expensive. So there is a savings there as well. Okay. So I guess, is there anything that can be done to expedite this being on some federal list? It has to go on a federal list, you said? Because we can't authorize funding to screen for it until it's on a federal list, right?
Yeah.
Or wrong?
The department likes to have the full evaluation of the disorder that the federal committee gives it to assure that it's the right thing for us to add it to the screening panel. There have been other disorders. All of these disorders are very heart-wrenching when you see kids with the disorders who haven't been treated, and the emotional situations that happen when families with children who have some of these disorders come to their legislators and ask them to add these bills. In other states, disorders have been added that were not appropriate to be on screening panels because the testing wasn't far enough along yet to be really accurate, and the treatment wasn't good, and in other states they've had real problems. California likes the vetting process of the federal list that assures us that these emotional additions that get required by legislation don't happen. So while we're very comfortable and confident that this is the right disorder to add, we're willing to not jump the gun and go with the whole process so that the next disorder that comes down the line, we can say, we look to the federal vetting process and we don't emotionally react. So we will wait.
Okay. No, I appreciate that very much. I guess my next question is that you talked about the particular thing inside of a cell or whatever, and I don't have a medical degree, so I apologize. So you talked about that. What is the cause of this? I mean, why, obviously this hasn't been around for, I don't want to say in my lifetime, or has it and we just not diagnosed it? Or, okay, so it has. It just has not been diagnosed in the past. Or is there a particular cause
I think
of it?
It's been diagnosed. So this is, if you watch movies, if you saw the movie Lorenzo's Oil, which is probably now 15 years old, Nick Nolte and Susan Sarandon, and was about a family who had a son with ALD. Okay. And part of the treatment was giving the son oil every day, but it didn't cure him. And that boy, I think he's still alive. He's in a wheelchair. He's very delayed. He has all sorts of health problems, but it was the family's effort to make him better. They have been able to create a test now that will diagnose these boys before they even have symptoms and allow them to be treated before the damage happens. So that's where a lot of these disorders go, is you may have never known them because the kids are so sick so quickly, and prior to being able to know about them and give them a bone marrow transplant, they died. So you probably wouldn't, as a kid who got sick one day, had a crisis, and a year later or 6 months later was dead. And so you don't see them or you don't hear about them because it's maybe 1 in 20,000, 1 in 25,000 boys.
Thank you for the information.
Mm-hmm. Welcome.
Any other questions from the committee? Public comment.
Hi, Justin Garrett with the March of Dimes. We advocate for the addition of newborn screening for all conditions once they are added to the recommended uniform screening panel. Given that AB 1559 does not require the screening until it is added to that panel, we would support the funding to allow the department to get ready for that newborn screening. We would also note it's our understanding that the equipment and technology needed for this screening would also be beneficial to other newborn screening conditions that are likely to be added to that federal panel in the future. Thanks.
Thank you. Okay, so on this item, staff recommends holding open the GDSP estimate and the BCP to allow for May revision updates. Staff also recommends that the subcommittee request the administration provide provisional language as part of the May revise if ALD has not yet been added to the recommended uniform screening panel. By then, that limits the department's authority to use these funds only for the purposes of AB 1559 and within the limits set forth in that statute. Finance.
John Boccigalupi, Department of Finance. If the subcommittee's action being recommended right now is to adopt the provisional language, just want to get on record that the administration opposes the adoption of the provisional language. We feel that it would impair the ramp up, the required ramp up period, and would impair facilitating the IT upgrades necessary to add ALD to the panel. Just wanted to get on record to express that.
We got you on the record, and the committee's not recommending action on the provisional language, but requesting it.
Okay.
Thank you.
Sure.
Thank you very much. Next item, issue 5, the Richmond Laboratory Capital Outlay Proposal. We want to bring forward Timothy Bowe, Chief Program Support Branch at DPH, Drew Johnson, Assistant Deputy Director, Center for Infectious Diseases. We'll have representatives from Finance and the LAO's office.
Good afternoon. My name is Timothy Bowe. I'm the Chief of the Program Support Branch for the California Department of Public Health. To my left here is Drew Johnson, who's the Assistant Division Chief for the Center for Infectious Disease. And his responsibility is the laboratory staff and the testing within the laboratory. My role and responsibility is the daily management and the operation of the Richmond campus facility. To give you a little background, the California Department of Public Health Richmond campus is a campus consisting of laboratories, office space, and warehouse on 30 acres in Richmond, California. It was purposely built in 2001 specifically for, at the time, the Department of Health Services. One of the laboratories that is there is the Viral Rickettsial Disease Laboratory, and we call it the VRDL Laboratory. And it is a biosafety level 3 certified laboratory by the Center for Disease Control. The requirement, and the Center for Disease Control regulates the biosafety levels based on to ensure that the safe handling of microorganisms. BSL certification consists of infrastructure, which is the facility, laboratory practices and procedures, and then personal protection equipment for the laboratory staff, and that will protect the environment and the community. The BSL levels consist of 4 levels, 1 through 4. 1 being the lowest degree of safety needed to protect the environment and the employees, and 4 being the highest. The VRDL is a biosafety level 3. At the time of construction, the Richmond campus was BSL 3 certified. In 2006, in response to various world events, specifically the avian flu, the Center for Disease Control added additional requirements to the BSL 3 certification requirements. In 2007, the California Department of Public Health submitted a capital outlay BCP for the newly adopted requirements. And in 2007, the BCP was approved, and $482,000 was appropriated for the first phase, which was the working drawings and the preliminary plans. The next year, in 2008, California Department of Public Health requested the construction funds of $2.5 million for the next phase of the project, was to actually construct the needed changes. But the project was not funded at that time because of the state's fiscal condition at the time. The project was suspended in 2009 when all the working drawings and the plans were completed. What we have before you is the same request to the capital outlay for $4.333 million to fund the BSL 3 enhancements that's necessary for the VRDL lab. The enhancements are still needed so that CDPH can maintain its BSL 3 certification. And we ask for your support. Thank you.
Thank you. Mr. Johnson, do you have anything to add?
Nothing to add this time. Thank you.
Thank you. Anything from Finance?
Carlos Ochoa, Department of Finance. No issues.
Thank you. Anything from the LAO's office? Thank you. Any questions from the committee? Okay. Staff is recommending approval of this request. I'm sorry. Do we have any public comment? Seeing none, we'll move forward. Staff is recommending approval of this request for $4.3 million general fund funds for a one-time capital outlay appropriation to upgrade the Richmond lab. Is there a motion?
So moved.
Is there a second? Motion's made by Member Chu, seconded by Member Grove. All in favor? Roll call.
Thurmond,
Yes.
Bonta, Chu, Grove, Jones. Has 4.
Thank you.
This is our final item. Thank you very much for your presentation. This concludes our meeting. Thank you, members. Thank you, presenters, and thank you to everyone from the public. We are adjourned.